To all who are new here, welcome to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are updating our upcoming schedule frequently, so check back often. For all athletic trainers who are intending to get live CEUs from the VOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz evaluation and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customer care at gotowebinar.com. Please ensure that this is done timely in order to receive your statement of credit. If you don't receive the follow-up email or have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review the questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. There is a handout for today's talk that's available for download from the dashboard, and the recording will be available afterwards from our website. Our speaker this evening is Dr. Mick Lynch, who is a sports medicine physician and author of the US Soccer Sports Medicine book and the International Olympic Committee Handbook series on soccer. He's also a past speaker at the US Soccer Symposium on the sports medicine of soccer. He is also an honorary lifetime member of the NATA. He completed his medical school at the University of Missouri in Columbia, residency at the University of Kentucky, and fellowship at Andrew Sports Medicine Institute in Birmingham, Alabama. He's presenting today on the management of soccer injuries. I'm going to let you take it away.
Okay. Hi, glad to have you guys join us. So, we'll talk about soccer stuff. And so I don't have any conflicts of interest, so we get all the administrative stuff out of the way right away. And this is kind of our overview, our course objective things that we're supposed to be doing. So we're going to talk about prevalence, so why are we talking about injuries at all? Some of the common ones and management ones and things. I'm going to spend a fair amount of time talking about prevention and then talk about a couple of interesting articles I've run across here lately about how to kind of globally think about management. I won't be so cavalier as to suggest that I can tell you guys a whole lot about the nuts and bolts of injury management, because you guys do that way more than I do. So the literature sometimes is kind of hard to get through, and a lot of that is because there's a boatload of different definitions. So these authors call it this way, these authors call it that way. This particular article I really like. They're aiming towards soccer, but the way they do the article, it really could go injuries across a bunch of different sports. So I really like how they're setting that up. If you're interested in doing some injury reporting yourself, I'd read this one. So they break it into medical attention injuries and then time loss injuries, and then they do their severity of the injury by how much time loss there is. And then in the article, they go through a bunch of other things. But for our intents and purposes, it's you got hurt, but you didn't lose any time, but it's needed to see the athletic trainer, essentially. Or you got hurt and you lost some time, and then how much time, and then they start stratifying across that. So what is the injury that caused you the most trouble? So if you like that kind of stuff, I'd really make sure you look at this article at some point, okay? Now, to get to the topic at hand, okay, so we've got soccer injuries, what we're talking about, and there's multiple levels. So we have, really elite professional level guys, and we have the elite professional level women, and then we go, in the US, we go with the college and, college men, college women's, high school boys, high school girls, and so we have these injury rates that are different because the exposure is different. Okay, so here, this first slide I've got, we're doing professional guys, okay? And so the range there's fairly big with incidence of injury. So 8 to 13 per 1,000 athlete exposure hours, so games and practices. Now, that's not horrible for us, because American football, this is very comparable to that. Right. But to put that into context, that exposure, that rate is 1,000 times higher than industrial rates of injury. And, and that's including a bunch of jobs I wouldn't want to be doing because they look dangerous. So in societal scale, this is fairly high risk and there's a lot of injuries. Okay, so the sports version of safety protocols, injury prevention, is really pretty important because the injury rate's pretty high. Okay, so if we run at that rate, and this is how it calculates out. So if you've got a team of 25 players, the usual college soccer team sort of stuff, you're gonna have 50 injuries per team, 2 injuries per player. So this is a lot like American football. Okay, now their seasons run longer, they play more matches, multiple matches in a week rather than just Saturday or just Friday night sort of thing. So the exposure is different, but prevalence is really fairly close. Now, I think you guys can't read this slide very well. So this is from a really recent article, and this is another one, when you pull the handout, there's a PDF of these slides. Pull this article and this table here, and it lists out the 31 most common injuries within professional soccer. In this particular table, table 1 here, they do a really nice job. So they list out how many injuries actually occurred over the 7 years, or 16 years in this case, in this particular article. And then they give you the mean duration of time loss, the median duration of time loss, and then the confidence intervals, essentially. So the 25th and the 75th. So you can really start to get a notion of, is this person you're taking care of right now, are they really falling out of what's considered normal standard stuff? So this is a pretty useful table. I'm sorry, it doesn't look to me like you guys are going to be able to read this very well at all, but it isn't. So this is another article that's quite useful. Hamstrings are the most common. Groin problems are the second most common, okay, in this grouping. Now what they do here is they categorize their 31, and there's a couple of hip things and a couple groin things and a couple hamstring things that I personally would group together. So I think they really kind of, what Americans do with how they're grouping things out. I think it's really a little bit more in the 20 to 25 kinds of injuries rather than the 31 that they're doing here. But this is a good table. Hamstrings, groins, and ankle sprains are going to be the biggies. And so that's, isn't a surprise to any of you guys. So that was the high elite guys, okay? Then the elite women, so professional women, they had a lower injury rate. So they're 3.8 per 1,000, okay? 2/3-ish, give or take, of the injuries were lower extremity. And that actually goes kind of across the board with soccer. Most injuries within soccer are going to be lower extremity. Now, this particular article, they also looked at risk factors, okay? And previous injury was the top, and that's also a fairly usual notion across most sports. So that's really nothing that's terribly new. So injury prevention, our safety protocols are a big deal, okay? Because I want to try to avoid that most common worst injury risk factor. Okay, then within this article, generalized joint laxity, knee hyperextension are risk factors, not a surprise to anybody. Now here, a high performance on single leg hop and balance tests were also considered a risk factor. So those women who were the better performance athletes had a higher injury risk. So, that kind of gives you pause about what you want to do with those things. Okay, so the rest of tonight, I'm going to be talking about, I want people to get really fit and I think that makes them sturdy. But this particular article kind of calls that into question a little bit. So that was an interesting notion for me. Okay. Now, male youth elite, okay, and so less than the male professional players, obviously. Okay, still, a fairly low. This particular article, again, competition had injuries higher than practice, also not a surprise to you guys. Okay. And then NCAA women's soccer, injury rate goes up, so 6.6. Okay. Again, higher in competition than in practice, and again, more lower extremity injury, so still nothing that's particularly new for you guys. Okay. High school girls had the lowest of the grouping, though there clearly are some injuries, ACLs and concussions, that are more prevalent in the high school girls soccer than in the other groups. But overall, when I'm kind of staying at the global notion, that's where we're sitting at. So they had overall the lower injury rate in this particular article. And then this is another one that I think it's quite good. So here's just the summary of what we did. So professional males had the highest, female youth, high school girls, okay, had the lower, okay. Now, injury type, injury location, that's fairly consistent across the literature. So as I look through all these different categories, and so I'm breaking it out by gender and skill level, okay, they're all still roughly the same. So lower extremities, most common. Hamstring injuries are most common and the biggest problem. A lot of recurrence. We'll talk about that a little bit later. Knee and ankle in practice and competition. In competitions, head and face injuries start to rise up, and they're certainly not the top, but they become more prevalent there. And then hip and thigh, so hamstring, quad strains, groin pain is more prevalent in practice. So like most sports, what occurs in the competitions is different than what is going to occur during your practices. Okay. Now, another thing to give us pause with this is there's this article that I'm referencing down there on the bottom, and they looked at overuse injuries, okay? And it's a nicely done article. I can't say that I really think it's terribly important for you guys to read necessarily unless you like doing research stuff, but they compared a couple of injury surveillance systems and had the researchers actually go to the medical records for the teams and look through what did the athletic trainers write down day to day, do the treatments, and what did the athletic trainers do reporting on the big surveillance system, NCAA, all that, and the high school thing. And only about 2/3 of the injuries that were overuse popped up in the reporting system. So overuse injuries in soccer are almost surely quite a bit more common than what we'll really read in this literature stuff, which, long season, more matches. So that also really isn't much of a surprise. But now we have some documentation that overuse injuries are a bigger deal within soccer than I would figure out by reading. Okay. Now, one of the bigger deals that I've been reading here lately with this is comparisons of acute and chronic workloads. It's getting a lot of attention. It's fairly hard to figure out right now because people are using a wide variety of definitions and methods. So they're basically the literature with this workload ratio stuff is breaking it down into internal workloads and external workloads. The internal workloads is what we're doing on this particular slide, and that's just your board rating of perceived exertion. And it's a pretty interesting notion that we'll talk about here in the next slide for all of us lesser mortals that don't have all the really fancy equipment. The external workload is some quantitative measure. So accelerometers, GPS, a lot of the European professional leagues are doing GPS monitors and all the players and figuring out how many kilometers they're doing, that sort of thing. Heart rate monitors. Within resistance training sessions, they'll calculate how much volume did you actually lift. You know, you're doing 150 pounds 10 times on the bench press, so that gives me a volume of weight that I've moved through that set, sort of thing. So that'll be our internal versus our external workload. Okay, the internal workload in this particular article and in a few other is a bit better with the older players. And my notion is that the older players have a better idea of what hard work is really like. And so with the internal workload, all they really did was they asked the players at the end of the session, training session, or end of the match, okay, how hard was that? So on a rating of 0 to 10, how hard did you work? And so they'd ask me every day, and I'd say, okay, today was a 7. Yesterday was a 3. You work through, and then they just add up what were my scores for the 7 days this week. And then they compare that to the average for the week before, to the average for the 3 weeks before, to the average for the 4 weeks before. And then they use those numbers, the acute, how hard did I work this week compared to how hard have I worked for the last 2 weeks or last 3 weeks or last 4 weeks. And they get the ratio. Okay. And with the external workload, okay, I'm wearing a GPS, etc. They do essentially the same thing, but they'll have some number. I ran this many kilometers, miles, if we're talking American, this week, and last week I did that, sort of thing. So they'll just plug in these numbers. And so the notion here is, when this is all said and done, I want a fairly high chronic workload. If I do a low chronic workload with a high acute workload, so I haven't been working very hard, and all of a sudden this week, I start doing all sorts of exercise. That's a setup for an injury. Also, not a surprise to you guys. Here they're managing to document, and I can do the internal way, which is really simple and fairly good, or the external way with the monitors. And lots of the professional clubs are doing that way right now. Okay, sudden changes in the load are problematic. Okay, and so here, when I do that calculation of the acute to the chronic, if I have a ratio of 1, then I worked so hard this week, I worked the same amount last week or last month or however, whatever my range is. Okay, if I go greater than 1, I worked harder this week than I did last week. Okay, which, you know, over a period of time, I want to slowly be working harder because I want to get more fit, right? Okay, now the issue becomes when your ratio starts to go up above 2. So if I work double harder than what I did last week, now I'm getting into a greater injury risk. So this could be a fairly easy way for people to start calculating. And if you're doing the internal workload, which most of us would have to do, since most of us don't have really fancy equipment, okay, or the manpower to do all the calculations, because that's also really time consuming to download all the accelerometers, all the heart rate data, all that sort of stuff. You can see, so the internal workload is basically asking, okay, how tired are you getting? Are you recovering enough? Okay, and if they're not recovering enough, so they're starting to scoot up to get to that 2 or higher, then you start got to ask them questions. How well are you eating? How much are you sleeping? In the college setting, how much are you sleeping is often a fairly big deal, okay? And you'll start working through there. So this chronic workload stuff, ratio of 2, starts to make me fairly nervous. All right, so next thing on the list is injury prevention. Okay, and so this, you know, I'm most interested in that. So, you know, the most popular one currently within soccer is the FIFA 11 Plus. Okay, and it's well documented. It works et cetera, et cetera. So I won't spend a lot of time with that because that's pretty easy to find, and I'm relatively confident most of you guys, most of you, have already seen that notion. So I won't bore you with going through that stuff. Now, it's often tough to get coaches to implement the FIFA 11 plus because it's time consuming. And so they want to have their players working, touching the ball, et cetera, working on tactics. So an argument here is, now I've got two articles that we'll talk about here. And so this one and the next slide, FIFA 11 plus for kids makes you a better athlete. So you do this program, you decrease the injury risk, and you make them a better athlete, a better soccer player. Okay, so in this particular one with the kids, so the FIFA 11 plus kids, they've added, okay, so it's the FIFA 11 plus standard stuff that you guys have already seen. And in this particular one, so in the youngsters, they add in how do you fall. So they essentially take judo moves, one of the very first things you start learning in judo is how to fall. So when you get thrown, you don't get hurt really badly. So in this particular, they add in another movement pattern that these young athletes won't be used to. And so they become better athletes, which will translate into less injury and being better soccer players. So this is another intriguing article. Here is the data from that same article. Okay, and so you can see over to the right here, they did what really worked. So on the left-hand side is a bunch of outcome measures that they did. So these are performance measures that, college coaches with a lot of good equipment would be interested in. What's your 20-meter sprint? How high can you jump? Several of those things. And off to the right is, okay, did it help? Did it not? Did it really help? And there's several things over on this right where it was beneficial. And a couple of them, as in the agility run is the one I really care about, was really beneficial. So this FIFA 11 plus for kids works. So it's a really strong argument to get your coaches to work these things. Okay, and then here they did the same thing with adolescents. So this was adolescent guys. So these are high school boys, and there's several things over on the right side where it was likely beneficial. So this makes you a better athlete. So these injury prevention programs, FIFA 11 plus for sure, also improve athletic ability. So it's gonna make your athletes a better player. So this should really be something that athletic trainers are pushing their coaches to do. Now, the notion here though is the athletes also have to take the warm-up procedure, and I'm using the warm-up procedure loosely here right at the moment. We're going to talk about that here in a couple of slides. You got to do it right. Okay, so the procedures you're going through with the FIFA 11 plus, they need to be able to be doing it properly. So early on in instituting the program, there needs to be a lot of correction. Do it this way, do it that way, straighten up, all that sort of thing. So they're doing the FIFA 11 plus properly, or otherwise it becomes a waste of time. Now, adding things in, so there's a couple of things I like with the higher levels of player. Okay, so the Nordic hamstring curl, no doubt that decreases hamstring strains. Okay, so it's quite useful. Okay, now we're going to talk more about that here in a little bit. This is a tough exercise though. The other one that I really like is the Copenhagen adduction exercise. And what you're aiming at here is to bring in some eccentric strength, so that negative strength, if we're talking bench press, positive and negative, lowering the weight, sort of thing. And I won't do it tonight, but there's some really interesting data that eccentric power, strength, however you want to list it out, is really, really important within sport and injury prevention. So if you're starting to lose your eccentric ability, your injury risk is going to go up. So I also think that this is a pretty important exercise to bring into your program, though both of these two are not easy to do. So, you know, I'm pretty skeptical that many youth players are going to be able to manage to do these two exercises properly. But that would be the aim, to get them strong enough that these two could get incorporated in. Now, injury prevention, it can't really start with the season. So this is going to be, it's all year round, going to be way tougher to do when you're talking about youth. But as you start to move into high school and then for sure college, okay, so the higher elite levels, or if we're in Europe doing the football academies where you're really designating this is my sport now, okay, these are starting the off season. And I look at this really as, I got to get you fit, okay? If you're fit, you're sturdy, I need to be careful about how I get you fit, not do too much all at once, not have a big acute workload, okay? But that's how you get people sturdy enough that they're going to avoid injuries. Now, within this article, and this is a pretty short one, that's pretty interesting reading, okay? That they kind of look more at a global and start asking, why are we doing this stuff this way? And they make the supposition here, so you make the suggestion that small-sided games are really important and fabulous for tactics and skill development, but they really don't necessarily complement what happens in a match. So they have a nice little Venn diagram in this article where they talk about, you know, do a lot of small-sided games, you get a lot of touches, okay? And that's what you need to be a good player, is you have to touch the ball and be coordinated with it, okay? But then I also have to be able to do sprints, and I need to cover distance when I'm in a match. And you don't cover distance very well in small-sided games. So there's a fair amount of change of direction in small-sided games, but you lose the sprint stuff. So their suggestion with this is, if you do a lot of small-sided games within your practices, you need to be doing some high-intensity sprinting so that they're getting the stimulus that's going to simulate match play. Then the other thing they talked about in this particular article is having some of this injury prevention stuff going the day after the match. You know, so that's typically a day off sort of stuff. But they're making the suggestion that when I'm going to do the hamstring eccentric exercises, Nordic hamstring curls being the easiest example with those, I should do them after the match. So the notion here is, a lot of players, particularly the pros, will talk about their legs being pretty heavy and tired after they go through this injury prevention stuff because of all the eccentric work that goes with that. And so, you know, a real common paradigm is to have people do injury prevention, go through that FIFA 11 plus really seriously 2 days before the match. Day before the match is a pretty light day where they're just walking through and thinking tactics and stuff, and then you got the day of the match. Well, if you worked pretty hard 2 days before, your delayed onset muscle soreness is going to be the day of the match, and you're going to have heavy legs. So their suggestion is that you put that back, and they're already sore the day after the match. You're going to do some work that's not real ballistic and not very, you know, not likely at all to hurt you. Okay? So I stay with the low injury risk, and I do my eccentric work day after the match, so that I'm going to get my eccentric work in for the week, but I'm not going to be doing it so close previous to a match that I'm going to be sore. So this is another article that, if you can pull it, this is a pretty good one to read. This really makes you think about how you're approaching things. Then, okay, we did this. So after training at practice, okay, so typically you will do the FIFA 11 plus as a warm-up, and it's, you know, really good warm-up. Okay, but this second article here, the level article, they looked at EMG activation before and after going through the FIFA warm-up with Nordic hamstring curls added in, and they really decreased eccentric strength. So if I'm worried about injury risk during practice, and there's, you know, a decent injury prevalence during practice, it might be better, might be safer to have the FIFA 11 plus occur after practice if I'm going to do a fair amount of hamstring work, add in FIFA 11 plus my Copenhagen adduction plus my Nordic hamstring. It may be better to do it afterwards so that I'm stressing the musculature, making them sturdy, getting my conditioning stimulus, but not doing it prior to a situation where I might be at risk because I'm in the middle of my practice. So switching the paradigm to doing the FIFA 11 plus warm up as a warm down is starting to have some pretty decent data to substantiate and back up the notion. Now, the good news for the coaches is there's this article, and they did this in male youth, so this is going to be grade school, middle school athletes. A 10-minute routine worked as well as a 20-minute routine. So doing the FIFA 11 plus, but getting it done in 10 minutes is also useful. Okay, so I don't have to do the whole long big thing multiple times and all that sort of thing. So you can scoot that down, get through a 10-minute routine, and it'll work fairly well. And then, you know, this would be fairly useful if I'm in fact going to do it after practice. So I can do a fairly quick warm down and still get injury prevention accomplished. Okay, now we'll get into, you know, a little bit more specific, though I'm not going to tell you guys how to do your jobs very much. So hamstring injuries occur when you're fatigued, you know, so most hamstring injuries are more likely to occur at the end of a match than at the beginning of a match. Okay, it's really common, you know, so an individual player on average in, you know, the European leagues misses 18 days in 3 matches. The club ends up paying somebody for 15 missed matches and 90 time loss days. So at that level of competition, this is really expensive. Okay, but what I really care about here is a bunch of them will occur. So up to a third of them, you get another injury in a year. So I really want to prevent it in the first place. And then they need a lot of time to recover. Now, one of the articles that I ran across, now it's a 2010 article, so it's not a new one anymore. But this is the first time I had read this one, and you need equipment to really do this right. So, you know, I'm not going to be doing it. But the notion here is they're doing a straight leg raise, okay, in a straight leg, you know, a knee immobilizer, so they're getting the whole leg to come up. And instead of looking at how far they can come up, our traditional straight leg raise, okay, what's your flexibility, they quantified how fast they did it. So I would just say, okay, so I, you know, get them on the table, strap the other leg down, say, okay, pick your leg up as high as you can, do it quick, but do it so you're comfortable, but do it quick, and then do the other side. And they, you know, did repetitions and all that, but there was a significant difference between how quick they would raise the uninjured leg and how quick they would raise the injured leg. So this group is using that as a measure, and once they get to where they do both legs at the same speed, now they're ready to return to play. So this is pretty intriguing, and one of the articles that we'll talk about here in a little bit, they made, you know, a series of comments about what's state of the art sort of thing, and they mentioned this test, but there's just not enough data yet for me to really say you should be doing this. But this is to me, a pretty intriguing notion that I want to look at self-selected speed and how willing am I to take my hamstring to a stretch and still be comfortable with making the move. So this one I think might come to pass to be important down the road, but it's not documented well enough yet. Okay, now what exercises are you going to do for your return to play, your rehabilitation stuff? Okay, so if I want to activate all of my hamstring musculature, hip extension exercises do a better job of spreading the activation across the entire hamstring. The Nordic hamstring curl, which I'm a big fan of, that selectively activates semitendinosus more than the biceps femoris. Okay, so if I've got a biceps femoris strain, I might be better off doing hip extension exercises, particularly early on. But even with that notion, the Nordic hamstring curl is still a big stimulus to the hamstring. On surface EMG, you got a lot more activation with the Nordic hamstring curls than you did with any of the other various hip extension exercises. Okay, and so this other article here is really aimed at track and field, but I like the way they break out the intensity. And so they're setting up a progression. So early on, I want to do these things. As I'm starting to progress to return to play and getting them ready to go back out to practice, I'm going to do these other things. So they break out pretty nicely groupings of how I'm going to progress my athlete through with this one. So this also, I think, is a pretty useful article. Okay. Now, how do I decide if they're ready to go back? Right. And so, there's a couple of things here that I really started paying attention to. Okay. So I thought about these things. So absence of pain on palpation at the hamstring. And, and lots of people will, and I used to all the time say, okay, you're a little bit sore, but how do you feel? Are you ready to go? And, your serious athletes, they want to get back and start practicing. They don't want to lose their spot on the team. Okay. But if there was persistent localized discomfort with palpation and you went back to play, even if it's just a little bit, okay, 4 times more likely to get a recurrence. So if I've already got nearly a third of my hamstring injuries occur in a year, I really want to start paying attention to this. So if they're sore to touch, probably shouldn't be getting them back out in practice. Okay, and then eccentric strength asymmetries. Okay, so if they can't eccentrically control one leg as well as they can the other, it's fairly hard to check. So this is not an easy thing to put into your evaluation scheme, but that's also a fairly strong predictor. That's actually the one I'm most interested in, but it's way harder to document. So that one's going to be a tough one. But both of these two articles here are pretty good think articles about how to work through your progression with your rehabilitation. Okay, now groin injuries is the other big headache with soccer. Okay, and it can really be problematic and last for a long time. So this article here by Enda King out of Dublin, this is pretty intriguing. So this is another one that I encourage you guys to pull and read. Okay, and so with this study, what they did was they took a bunch of people and they filmed them, and they did some really nice 3D biomechanical analyses and broke it out into 3 different ways that people compensate for their groin injuries. Okay, and then they couldn't, they broke it out into where was the injury, et cetera, and they couldn't really say that, pubic aponeurosis things do it this way and adductor magnus things do it this way. It was sort of I self-selected with which compensation pattern I particularly used, and I could have any of those. So what they did was start to try to figure out how to fix the compensation pattern. without really worrying so much about what the particular groin injury was. And so this is their progression. And so they started out with intersegmental control things, and it's, it's pretty straightforward. And they're not doing anything that you guys probably aren't, you guys are already doing this stuff, but they're doing a really nice job of setting their progression. So these are the things I'm going to start with. And it's going to be trunk control, and they have a really nice graphic within the article about each section, and so foot and ankle, knee, thigh and hip, and I'm targeting these things. And they list out several exercises within each level. And these are the things I want to do. And if I can figure out, if I have the biomechanical testing and figure out really which compensation pattern they're using, then I can target those particular things. Though most of us aren't going to be able to do that, but they set up a really nice paradigm for progression. And then you start doing linear mechanics, straight ahead running, and then they start moving into change of direction and sprinting. Okay, so this is another place where they're really thinking about what their progression is, and they did all the work identifying the compensation patterns and worked it through. So this is another one that I heartily encourage you guys to look at. So those will be my hamstring and my groin things. Ankle sprains, that's bread and butter for athletic trainers, realistically. Okay, so here's the thing. So the worry here is, am I going to turn into chronic ankle instability? So these are prognostic factors that make me really nervous. Okay, can't jump and land within 2 weeks. 8 weeks, you still have a really floppy ankle, anterior drawers, high, all that sort of stuff. Now the two middle ones, the dynamic postural control and the hip kinematics, those are a bit harder to quantitate, okay, but also problematic. And in particular, the dynamic postural control deficiency, ankle rehabilitation is really working on balance at time. So it makes sense that we're having that sort of stuff. Then, there's clinical decision rules. And so the auto ankle rules are the biggies, but I wanted to list out these other ones. The bottom two have some pretty good data. The top right one, the Bernese ankle rules, a lot of people talk about, but there's just not great data. So that one I'm fairly lukewarm with. The auto ankle rules is still, at least in the US, by far the most commonly used. But I wanted to show that there are, in fact, some other choices if you want to branch out a little bit. Okay. Ankle strength, early exercise therapy, particularly under supervision. So that's what athletic trainers, physical therapists do. So there's no doubt that the early mobilization or early movement and exercise helps ankle strength. Okay. Manual mobilization, recently, they're getting some pretty good data that it's useful short term. That's been, accepted for a fairly long time. But for quite a while, nobody was showing that that would make a difference a year from now. But it is, in fact, useful, and there's some fairly good articles. This update here down at the bottom goes through the literature very, very nicely. And in the usual ice and compression, I'm a big fan, okay? But there's always, lately there's been arguments about, is ice a waste of time, all that sort of thing. Ice alone and compression alone are a waste of time, okay? But ice and compression, particularly ice, in my opinion, working through with exercise, balance, drills, et cetera, does in fact help and shorten time loss with those. So I'm a big fan, and the literature is starting to back up the manual mobilization and the ice and compression if used in combination. Also, almost surely not news to you guys. Okay, and I think the last thing that I want to chat about, okay, and I actually have zero documentation for this, okay, but the groin stuff. Somebody's got persistent, recurrent groin injuries. I think they should be going on rollerblades and adding in a fairly safe stressor that's going to combine some balance, some different movement patterns that will help. And it's, if I can rollerblade okay, there's probably not going to be a lot of ballistic movement with it as well. Okay, so that's the one last thing with management with a common soccer injury that I'm a fan of, but I'll readily admit I've got zero data in the research literature to actually back that up. Okay, so that's what I have. I'm happy to field questions when Michelle lets me.
All right, I'm back. So the first question comes from Karen, and she is asking, could the single leg hop be a risk factor because those athletes are also more aggressive on the field?
Yes, and that actually is my supposition. Okay, now I can't tell that, you know, that's what I think, but I don't have any data. But yes, I think that Karen is absolutely right on that.
Okay, and I have a long question here, and it comes from Jason Torres. He's asking, he says, what are your thoughts on immediate leg immobilization after hamstring injuries, in addition to ACE bandage securing a foam pad on the injured musculature? And he references a very interesting article I'd read, allows for reduced time before beginning a functional and dynamic rehab. The study showed low re-injury rates, approximately 6% after 6 months, and return with 3 weeks with both grade 1 and grade 2 injuries. Just wondering your thoughts on hamstring rehab, as it is the most prevalent and has the highest re-injury rates of lower extremity injuries. And then he references the article here.
Okay, I want to see the reference for sure because I'm going to read that. All right, so that makes me a happy boy to get references out of stuff like this that I think I haven't run across yet. So, you know, that's a fascinating question. And, you know, you can do the same thing in ankle rehab, all that sort of stuff. You know, conceptually, I want to immobilize. So, you know, so any of those things, if it's hamstring, musculature, ligaments, I've got this tissue and I just ripped it and I want it to knit back up in a relatively, you know, return to architecture sort of thing. So yes, I want to, you know, immobilize and not accidentally pull on it. The question becomes, how long do you immobilize it? Okay, and so if you immobilize it too long, you start getting all your muscle loss and neural loss and all that sort of stuff. So, you know, I'm ancient enough, you know, so I did my training last century, you know, and when I was doing this, the big argument was, you know, they were on the tail end of the argument. Well, do you put an ankle sprain in a cast and keep them in? And then, you know, and so we're, you know, I got trained, oh my God, you don't do that. You know, don't put them in a cast because that's, you start up early mobilization and all that sort of stuff. Well, now everybody puts them in a boot. Okay, so you're real, you know, you're not totally locking in like a cast, but you're not allowing much range of motion. Okay, but you can peel it off and start doing the range of motion. So that's a fascinating question. So I won't say that, you know, you shouldn't immobilize the leg at a hamstring injury. Okay, because it, you know, conceptually, I'm letting those muscle fibers stay pretty close to their neighbors that they just got separated from. Okay, but the big question becomes, how long is too long? So
He actually, yeah, I'm gonna mention this because he did add a little update here. Immobilized for 48 hours was apparently.
Perfectly, you know, because that's just, you know, that's just the flip side of the thigh with the West Point and the quadriceps hematoma stuff, where you pull them, you know, pull their heel to the butt and tie them up like that. You know, West Point did great stuff. That was in the 1970s, I think, is when that article came out. So the concept is well documented. Okay, the notion is, given the particular injury, how long is too long? And you don't want to go too long, but 48 hours, that's really interesting. When I get that reference, I promise you I'm going to pull it and I'm going to read it.
All right, so Andre has a question here. With one of the earlier articles mentioned in the presentation, you stated that the researchers noted that elite female athletes who scored well in single leg hops and balance testing were also in risk of lower extremity injuries. Did the article have a correlation to the reason why?
No, they did not. Okay, and I haven't found something yet that makes a guess on that. So I'm with, the first question, Karen. I think it's they're just probably, they're fitter, they're more aggressive, and they put themselves in situations where they might get hurt. Okay, which is, means they're better players. Okay, so that's my guess, but I haven't found anything yet to back up my guess.
Okay. Shay asks, do you recommend or have research on what is best for hamstring strains as it relates to ice or heat?
I'm a big ice fan. Okay, that, see, let me, oops. Okay, so this Vanderhorst article, that's the best one I've seen here lately about hamstring work. So I'm a big ice fan, and personally, I hardly ever use heat. Okay, but that's a lot of that is because that's the way I got trained. All right, so I'm certainly biased. I have my confirmation bias because that's the way I got trained. But I do, in fact, think it's reasonable prior to activity, to heat somebody up before they're going to go to practice. Okay. But, in fact, that slide I'm showing now, if you guys can see it, okay. If they still hurt when I palpate them, that's going to make me a little bit nervous. So I'm going to be slow about advancing them into more and more activity if they're sore. But I personally am not a big fan of heat, but I also do not think it's wrong. But I use it in, I think it's a niche product prior to mandatory activity. I'm going to practice.
Okay, this comes from Isaac. He said, thanks for the presentation. When you speak on ice and compression in conjunction with therapeutic exercises, are you referring to ice application before or after therapeutic exercises? Likewise, with compression, do you advocate for blood flow restriction rehab or compression following a bout of therapeutic exercises?
Okay, so let's go with the ice one first. Okay, I'm a big fan of ice. Okay, so I am clearly biased, and that's the way I got trained. So you kind of have to take me with a little bit of a grain of salt. I ice before and after. Okay, now the notion I have, so Ken Knight from, this would have been in the 1970s. So Ken Knight, the Indiana State prof, did fabulous, one of really, really strong early athletic training researchers. And his articles, postulated, I think showed, okay, that you ice them, yes, you cool everything down, they're a little stiff, don't quite feel like they can do stuff as well, but you decrease the swelling, and for the rest of the day, they have better range of motion, better blood flow. So that this particular article, that's really what Ken was driving at, is the notion, well, if I ice you, I decrease blood flow for a little while. If I heat you up, I increase blood flow for a little while. And so he, yes, that's correct. But then he also added in the notion that what's going to happen for the rest of the day. And if I ice you, I decrease swelling, I improve range of motion, and therefore improve blood flow for the rest of the day. If I heat you up, I don't help the swelling, and I lean toward you increase the swelling a little bit, but that's my bias. So you do nothing for the swelling, which is going to decrease range of motion for the rest of the day and decrease blood flow. So Ken, I think, showed, but at least hypothesized, that for a 24-hour period, icing is going to give you better blood flow for the 24 hours than heat. So I like ice before and after. but I'm biased.
Okay. Jessica asked, do you recommend the FIFA medical diploma?
Kind of depends on what you want to do. Okay, so if you're a high school athletic trainer, you know, I mean, it's good stuff, you know, so yes, I think it's really good information to get if the certificate is gonna, you know, having their credentials is gonna help you out, get a better job, work up a level, something like that, then yes. But it, you know, I'm at a small little school and I ain't going anywhere. So for me to do that, you know, I think it'd be fun. Should I spend the money to get that? Kind of depends. So that's a pretty individualistic question. It is a lot of really good information, but can you use that certificate to improve your status? Because you can get all the information if you just sit down and read like I do. Okay, because their, you know, their certificate is just going to be this data was out of this article, this data was out of this article, and they're going to put it in a nice package for you.
There's another question coming here from Nadine, and she's talking about ultrasound. She likes ultrasound early on to help with breaking up hematoma. And she's wondering if you know of any good articles that relate to ultrasound for hematoma. She says this is about the only time I am using ultrasound.
I think I can find one. It's escaping me where I stuck it, but I think I saw one not all that long ago. So if
we can get it to her then.
If we can connect after, I'll try to find one. Okay, I think I've read one not all that long ago, but it's escaping my head where.
All right, and then we had two folks come in and just mentioned that the FIFA diploma is free.
Oh, is it? Good for FIFA. I really thought there was a charge to it. I was just wrong. Okay, then yes, if it's free, I heartily recommend it. Okay, I thought there was a charge.
Okay. And I'll connect Nadine's email address with you. And okay, last question here is in regards to what's your level of concern about a rotated innominate contribution to chronic hamstring strains?
Okay, you know, a lot of that's a really interesting question. Okay, a lot of that depends on what your training was. Okay, so I never, you know, so you do up slips, down slips, all that sort of stuff. You know, so you're an innominate person. I got trained as a sacral guy. Okay, so I do, you know, sacral rotations, and you know, I kind of get the innominate stuff, but frankly, I'm a bozo when it comes to the innominate stuff. Okay, but I think, yes, that sort of thing is really important. Okay, and so if you can correct that deficiency, then I think you'll make them better. All right, but I look at it, you know, this is all postural, and it's all muscle lever action kind of things. And if you're at a mechanical disadvantage because an insertion isn't in the right place, you're more likely to get hurt. So I can't really specifically talk about that particular innominate thing because I'm a bozo with innominate things. But I do like that notion. Okay, I'm a sacral guy, you're an innominate person. Okay. But yes, I think that theory is quite good.
Well, excellent. Thank you so much. We are getting ready to wrap up here, and I wanted to thank you, Dr. Lynch. A fantastic speaker as always. Gave us a lot of good research here, a lot of good articles, and you know, initiated the conversation that will continue moving forward. We had quite a few of the athletic trainers just very excited to see you as a speaker here today, so I wanted to pass that along. And we do have 2 upcoming webinars that are going to be in about 2 weeks. And before we conclude, is there any final last words that you would like to share?
Oh, me, I'm sorry, I thought you were asking.
Yes, indeed.
No, pull some of those articles. All right, several of those articles are really good. The Vanderhorst hamstring one, the update ones. Personally, I thought this was a lot of fun to prepare for because I got to go back through several articles that were quite good. Probably the Enda King one about the groin rehabilitation is probably the one I'd do first if I were you.
Perfect. Because there's so many articles out there, and you're always sending some out, so it's helpful to have a jumping off point. I appreciate your time tonight. Thank you everyone for coming. You'll see the emails coming out here soon, and we look forward to having you again on a future webinar.